I'll start my 5 minutes with the scary numbers. You've seen numbers like this over the last 2 days. The thought that a third to half of antibiotics written for human medicine are medically inappropriate or completely unnecessary, that's terrible. That's unacceptable. The deal is, though, when I talk to physician colleagues, I don't find any of them who say, well, about half of the prescriptions I write for antibiotics are completely unnecessary. In fact, you'd be hard-pressed to find a physician who would publicly admit that any of the prescriptions they write are unnecessary. There was a reason why they wrote them. So there's a disconnect between perception and between what we're seeing in the numbers. Maybe a classic case is upper respiratory tract infections. They're almost all caused by viruses, and yet antibiotics are frequently written for those. That seems like a pretty open and shut case. Unnecessary, inappropriate. But as our poultry farmers know, viral respiratory infections can go on to bacterial infections. And the physician who's actually seeing a patient has that in mind when they're writing. So in their mind, that antibiotic may be both appropriate and necessary, or they're not sure. We learned yesterday stories are very powerful. So I'll tell my little story from last week, which is actually a true story. Volunteering in a charitable clinic last Thursday evening, along with a colleague of mine who's a cardiologist. We finished up. I decided to stay to review some lab work, and then the nurse brought up the last chart from my colleague and asked me to write a prescription that he had forgotten to write. And this was for a young woman who had a sore throat. And I noticed that he had written for a broad-spectrum antibiotic. I thought, well, maybe I better review the details. She happened to still be there. So I talked with her a moment, took a look in her throat, and concluded that this was actually probably due to postnasal drip from allergic rhinitis. Explained to her that probably an antibiotic would not be helpful, and wrote her instead for an over-the-counter antihistamine. And reflecting on that, my colleague was very well-intentioned, very bright physician. This happened to be the last patient of the evening. She happened to be the daughter of the pastor. And he was really working outside of his area of expertise. And those are all particular to this story, but they also are generalizable a lot. Many times our physicians are working under pressure. They need to make decisions quickly and with some level of uncertainty. Sometimes there is pressure from families and considerations that would influence their judgment. And the reality is that many of them are working outside of their area of expertise. Now, I'm trained as an infectious disease physician. I did 3 years of infectious disease training. If I went into my hospital and tried to schedule myself to do a surgical procedure or a cardiac catheterization, they would not schedule that. I had my cardiology rotation as a resident, and I did a surgical rotation as a medical student, but those are somehow not considered sufficient to qualify me to do those cases today. But everyone feels like they can prescribe antibiotics, even if they haven't had any specific training in those agents. And patients feel the same way. I've never had a patient come in demanding chemotherapy or demanding, doc, I think I need dialysis today. But many of them want antibiotics. So as I've heard the frustration from the animal agriculture side over the last few days about very simplistic presentations in the public space, it's the same on the human side, and true leadership requires understanding the realities and complexities, not just the sound bites. This is a slide that you've seen before, a much more updated version that Chris Braden presented. The slide that I had sent had my state circled, Arkansas, and although I'm glad that for once we're not the worst, still, at least in 2011, we had 1,149 prescriptions per 1,000 population. So more than one prescription of antibiotic per every man, woman, and child in the state. Now, I don't think I got any last year, so someone got 2. And if you look at the pattern, you'll see that prescribing patterns differ geographically, and that there's a concentration in the South of high prescribing states. Part of this is physician practice, patient expectation, I'm certain. But part of it is the realities that we deal with in the trenches. These are states, and I'll talk about my own state of Arkansas, high level of poverty. General health tends to be lower, higher rates of obesity and diabetes, higher rates of tobacco-related pulmonary disease. And so we have patients who are coming in who in some ways are sicker than perhaps where I did my training in Texas. Also, access to care is a challenge. If your patient is coming from a county or two away, they had to get transportation from a friend or family member, and they couldn't pay their copay, then the wait and watch approach is not very viable. And so sometimes antibiotics get prescribed in those settings when they might not in a higher resource setting. If you look at prescriptions for prescription opiates as well, you see a similar pattern with the southern states being high prescribers. In Arkansas, we a few years back had a very intense educational effort to educate the public, change the prescribing patterns of physicians, and we saw very, very little impact, and it was transient. And I think part of the reason is that it doesn't change any of these on-the-ground realities, these fundamental facts that physicians face. The other thing that education doesn't change are the financial incentives. In clinical care on the human side, really all the incentives are towards prescribing and not towards stewardship. I remember 20 years ago when I was doing my training in Houston, the infectious disease faculty there developed one of the first effective antimicrobial stewardship programs. They were able to demonstrate impact, published their findings, and actually were able to calculate how much money they had saved through that program, and it was far more than the cost of the program. Nevertheless, the hospital decided not to fund the antimicrobial stewardship program because it was costing the hospital, and those savings were actually saving the hospital money. They were saving the system money. So the financial incentives were not aligned. Now, the initiatives by CMS and Joint Commission are very promising and should help to align incentives. In this slide, which you've also seen before, it shows the percent of hospitals with antibiotic stewardship programs by state. Arkansas is in the lower category. I'm happy to report that at this point we have 35 hospitals that have programs with all 7 of the core elements, and over half of our hospitals have at least 6 of those elements. Almost all of them have at least one of the element in place, and so we're making progress, and with these financial incentives by CMS, then we should see greater progress. So aligning the incentives is key in leadership in this area. This is another slide you've seen before about the CDC's program for Get Smart About Antibiotics. We found these materials to be very helpful in our state efforts. We've been actively involved with that since 2013. CDC, though, has also put their money where their mouth is, and with the new antimicrobial resistance funding, we are actually for the first time receiving specific funding for antimicrobial stewardship at the state health department level. Currently, we've been covering that in our healthcare-associated infection program. And I'd like to conclude my remarks with just a sense of where a small southern rural agricultural state is at their health department level in terms of our priorities for leadership in antimicrobial stewardship. These are elements that should be very familiar to you. Preventing infections, data for action, engaging stakeholders, of course using our CDC materials and our partnership with them, continued partnership, building on our healthcare-associated infection partnerships, trying to build those partnerships for a true One Health approach, and hopefully developing an antimicrobial stewardship statewide plan, maybe not with all the bells and whistles of Minnesota, but at least moving in that direction. So to conclude my remarks, I think leadership in antimicrobial stewardship, at least at the state health department level, involves collaboration. It involves understanding the drivers of behavior, because that's our only chance of really changing those. And then for sustainable impact, aligning incentives so people are able to do the right thing, but able to do the right thing in a way that doesn't hurt their interests or the interests of their patients.